the xanthines, and the prototype drug is aminophylline. This is discussed on page 126 in the ATI book. And these have been given for more serious cases of asthma, the kind that can land you in the hospital. So you want to read about that in the ATI book. These are given usually IV drip when you're in the hospital, and they can be taken orally too. But they can have very strong side effects. They work to relax the smooth muscle in the bronchial passages and just kind of keep those blood vessels in the lungs constricted so you don't have that swelling and edema. They also act on the kidneys to make you increase urine production. So this can be helpful if anybody's got any excess fluid. These would be excellent in patients with congestive heart failure, except they're very strong meds with a lot of side effects. So generally they're not used routinely for that. They also have central nervous system effects. So people who take these report feeling very, very shaky. I mean, you'll actually see their hand shake. Sympathomimetics can give kind of a little sensation of feeling shaky. You kind of get a fight or flight type reaction, but the xanthines have a very pronounced central nervous system effect. Xanthines are chemicals that are very similar to caffeine. They are like caffeine's stronger, less easy to control cousin. And so they make people have the same kind of reactions with caffeine, only more so. So sometimes doctors will use aminophylline or theophylline as a therapy along with other chronic treatments for severe asthma, severe bronchitis, emphysema, where the person is just really not reacting to the things that they've been taking at home and need hospitalization. Because this stimulates the central nervous system, sometimes in the neonatal intensive care, very, very early preemies might be hooked up to a very, very small drip of aminophylline because it stimulates their central nervous system and keeps them from going into apneic periods. Acute pulmonary edema from fluid overload or other conditions can sometimes be helped quickly because of the double action of relaxing the smooth muscle and working on the kidneys to get rid of excess fluid. Now, they don't use these now unless they just absolutely have to because of the severe side effects. But they can be a very useful adjunct treatment. So make sure you read about these on page 126 in the ATI book, because they are often used when needed. So make sure that you differentiate between the short-acting beta agonists, sometimes called SABAs or SABAs, and then the long-acting beta agonists, LABAs. And our prototype is salmeterol for this. And I'll talk about salmeterol again when we talk about steroids for asthma and COPD, because many times they will mix these two medications together and give a very good, effective treatment for asthma and COPD. So we talked about nasal corticosteroids. So let's talk about inhaled corticosteroids for asthma and COPD. On page 120 in your book, we see the prototype fluticasone discussed. And fluticasone is a very common inhaled steroid. They can put it both in a nasal spray or a nasal inhaler and a pulmonary inhaler. Flovent is the name for fluticasone just by itself that you inhale into your lungs because it decreases the immune system response that releases histamine, leukotrienes, and all those other cytokines and other inflammatory chemicals that want to come through and clean everything up. Fluticasone by itself, they call Flovent, and many times they'll mix fluticasone with that salmeterol, the long-acting bronchial, or the long-acting beta agonist that I talked about before, and then that's when you get Advair, the big purple inhaler. So it's got a corticosteroid for long-term treatment, and then it's got a long-acting beta agonist. So, of course, Advair is not going to be used as a rescue inhaler either. So the only one that you can consistently use as a rescue inhaler, and you always had to have with you if you are an asthmatic or somebody with COPD, is that albuterol. Make sure you have that. On page 119, they talk about using a metered dose inhaler. That's an inhaler that kind of measures out every dose and lets you know how much you have left. There is an ATI scenario for use of a spacer with an MDI that I will try to remember to show you. And it's very important when you are putting a patient or educating a patient about a new inhaler to show them how it works. And if you don't know, you need to ask the pharmaceutical rep for a demonstration inhaler. There are a lot of inhalers, and boy, some of them are very complicated. And I've seen some that I've had to really fiddle with to figure out. And if a nurse has a hard time figuring them out, imagine a patient maybe who's not really familiar with that equipment. So figure out how to use it yourself and then demonstrate it for the patient, because it's not going to do them any good if they can't use it. The inhaled corticosteroids, once again, are for prophylactic or preventive use against future asthma and COPD attacks. They are not to help somebody if there's an acute attack. If they are wheezing and immediately short of breath, they need that albuterol. I'm going to stop here because it's getting close to 8 minutes, and 8 minutes is kind of my limit per lecture. So then we'll talk about expectorant medications.